കേൾക്കുന്നില്ലല്ലോ. കിഷോർ, can you hear me?
ഹലോ
ഹലോ.
ഹലോ
കിഷോർ. ഹലോ. JP വന്നു. JP വന്നു.
കിഷോർ സാറ് മ്യൂട്ടാണ് സാറേ.
കിഷോർ വിളിക്കണോ ഞാൻ?
കിഷോർ സാറ് മ്യൂട്ടാ. വീഡിയോ കാണുന്നില്ല, ഇപ്പം മ്യൂട്ടായിട്ടാ ഇരിക്കുന്നത്.
മ്യൂട്ടാ?
മ്യൂട്ടാ സാറ്, മ്യൂട്ടാ.
ആണോ?
എക്സിറ്റ് ആയി പോയോ? പക്ഷെ സാറിനെ കാണിക്കുന്നുണ്ട്.
നേരത്തെ കണ്ടിരുന്നു.
പേര് കാണിക്കുന്നുണ്ട്, പക്ഷെ
വിളിക്കണോ ഞാൻ?
ഫോട്ടോ വീഡിയോ കാണുന്നില്ല. മാഡം സാറ് പക്ഷെ ഇന്ന മാഡം അകത്തുണ്ട് ആള്.
കേൾക്കുന്നില്ല അല്ലേ? കിഷോറിനെ കാണുന്നില്ല. ലീവ് ചെയ്തിരുന്ന
സാറിനെ എന്നാ വിളിച്ചാലോ മാഡം? ഇതിന്റെ സാറിനെ കാണിക്കുന്നത്.
പക്ഷെ ആരും കാണുന്നില്ല കാരണം കുറെ ആൾക്കാർ ലൈവ് ഓക്കെ
കിഷോർ
മാഡം കേൾക്കാനുണ്ടോ ഇപ്പോ?
കേക്കാം.
ഓക്കെ ഓക്കെ. ഞാൻ
ഡോക്ടർ
വീഡിയോ
ശ്രീലത, can you welcome? എന്ത് പറ്റി? ടെക്നിക്കൽ.
ടെക്നിക്കൽ എന്തോ പ്രോബ്ലം ആണ്.
Okay, now you're okay?
I think so.
Ella, you had shared the slides actually before, Ella, but then suddenly it went off. Dr. Srilada, are you there? Can you welcome?
Yeah.
Ah.
So, good afternoon. I'm Srilata. Dr. Kishore ഞാൻ നേരത്തെ പരിചയപ്പെട്ടിട്ടില്ല. അപ്പോൾ
Hello,
hello. So first of all, we thank the Department of Pediatrics, Kottayam, is thanking you for accepting our invitation and agreeing to present this class, this topic for us today.
Always a pleasure, madam. Thank you.
So I welcome
Srilada, നമ്മുടെ alumni ആണ് കിഷോർ. She did her MD from Calicut.
Oh, I'm serious.
MBBS. So that, okay. So I welcome Dr. Geeta to
DCH in Calicut.
Okay. So I welcome invite Dr. Geeta to introduce the speaker to others.
Yeah.
So good afternoon, everybody. I'm extremely happy to introduce Dr. Kishore Chandra Warrier, who is a consultant pediatric rheumatologist at Nottingham Children's Hospital since 2013. Hope I am audible. Am I audible?
Yes,
ma'am.
audible.
So to introduce him, he did his MBBS from Trichure Medical College, his DCH from Calicut Medical College way back in 2000, Kishore? 2001.
2000.
Yeah. And I was a junior MO at that time. So my association with Kishore starts from there. He was one of our pet students. Then he continued to do his DNB from Trichure, and then he migrated to UK, where he did his specialized training in pediatric rheumatology at Great North Children's Hospital, Newcastle. Now he's an eminent pediatric rheumatologist at Nottingham Children's Hospital since 2013. And he's currently chief investigator and principal investigator for a number of clinical trials in UK. He's chair juvenile dermatomyositis group, member UK vasculitis, it goes on and on. He's an invited speaker of many distinguished, many conferences in UK. See, we are very much associated. When I was in Calicut, we were very much associated with him because every year he comes to Kerala somewhere in July, August. And for the past many years, we have been having sessions with him. We have almost half a day, 3/4 of a day with him. We keep all the difficult cases accumulated, and we present and we gain a lot. And he gives us a talk also. And not only that, whenever we had a problem, he's always at the other end of the phone. He always helps us in many ways. So, and he, he's a very good, he's an all-rounder. Nallona paattu paadum. He's a very good percussionist, and we have had many programs together. Okay. So, welcome, Dr. Kishore. First, I think he's going to deliver a talk on lupus, and then we will have an interesting case discussion by Dr. Roshni will present that case of lupus in our hospital today. Okay, over to Kishore.
Thank you very much, Geeta, madam. It's always a pleasure talking to the Kerala audience, and I cherish that very much. Can you see my slides? Is it being shared at the moment?
Yes, we can.
Okay, fine. Thank you. So I think my video is not working, but I think I'll stick to slides, and because my audio is working. Is the
Can you make it slideshow? Slideshow, Kishore.
I've just made it in slideshow. Is it slideshow for you? Is it moving?
No, sir.
Okay, all right. What about now? Is it moving?
Not, I think.
No, sir, it's not.
It's not slideshow.
All right, I'll try again. What about now?
Yes.
Yes, yes.
Is it moving now?
Yes.
Is it moving? Okay,
Yes,
thank
yes,
you.
it's moving.
So,
You can continue.
thank you very much. Yeah, we had a discussion, Geeta madam and I, about what topic I should choose, and I've chosen lupus, and obviously you will understand why I have chosen this title. So it's not just about butterflies in children, and I'll put things into perspective as we go along. And hopefully we'll have an interactive discussion at the end of. This presentation should take me about 45 to 50 minutes, and then obviously there is a case presentation and we can discuss more about it. So why is it not just about butterflies in children? So the order of play today, I will discuss a few cases. Then I'll talk to you about lupus and lupus nephritis, focusing on the treatment, and then a little bit about the prognosis and outcome. So without much delay, I'll start with the first patient. Is a 15-year-old boy of South Asian origin, and the ethnicity is important. And again, I'll come to that later. So I saw him exactly, if I remember right, on the 31st of December 2025 on New Year's Eve. So the story is he was referred because of lethargy, fatigue, and joint pain for about 5 to 6 months. So this boy is very clear that I'm just not the person I was. He was not himself for the last 6 months. So he's a boy who was very active, very clever in academics. He was playing a lot of cricket, and he used to do sports. And for the last 6 months, he's just increasingly tired to the extent that when he comes back from school, he's too tired and just goes to sleep, which was very unusual for him. The family were particularly concerned about swelling they had noted around his eyes for the past 2 or 3 months. That was clearly worse in the morning. So when he woke up, he could barely open his eyes because of the swelling. So it was periorbital edema, but it was not associated with any itching, erythema, or other rashes. And more importantly, he did not have any swelling of his feet or scrotum to suggest this being nephrotic syndrome. So you can see that this is his photograph in the morning, and he's really got swollen eyes. And obviously the swelling still persisted, but got better as the day went on. So they went to GP as is practice in UK. So the GP felt it was allergic, and he also had a background of urticaria. So the GP gave them some antihistamines, couple of different antihistamines, but he had no response. So then he undertook some blood tests, which picked up low platelet count accidentally, and he was referred to my hematology colleagues. So when he saw the hematology colleagues, they were obviously worried about nephrotic syndrome. So they checked urine protein creatinine ratio, which was normal. His chest X-ray was normal. They were worried whether this could be some mediastinal obstruction that is causing it, which is normal, although it was less likely from the symptomatation. But they made a diagnosis of ITP with a low platelet count of 66,000. Incidentally, he was also picked up to have low vitamin B12, and he needed injections for that, and low vitamin D, which was treated. As a part of the workup for ITP, he was found to have positive ANA, and he was referred to us. So thinking about periorbital swelling, just going back to a pediatric practice, what are the differential diagnoses we would think of? One obviously would be allergy or urticaria. But if it's allergic, it's unlikely to be so symmetrical and or show any diurnal variation. Plus, this boy had no itching at all and it didn't respond to antihistamine. So it looked less likely to be that. Obviously, one of the things which would come to our mind is whether this is nephrotic syndrome. And actually, he looked like a boy with nephrotic syndrome, but he had no ankle edema, scrotal edema, and his urine PCR were normal. Mediastinal obstruction comes to our mind, but the mediastinal obstruction usually affects the lower half of the face, and usually we would expect dilated veins. He didn't have any of that. And in fact, it was restricted to periorbital swelling. From a rheumatology point of view, one of the rare differential diagnoses for periorbital swelling is juvenile dermatomyositis. So often patients with JDM have periorbital swelling, but that's almost always associated with the violaceous heliotrope rash, and he didn't have any skin changes at all. So we were all a bit baffled about what this could be. So when I saw him in clinic, I revisited his history, which was pretty much same: 6 months of tiredness and periorbital swelling, worse in the morning for the past 6 months. He had some musculoskeletal pain, but no clear evidence of arthritis. More importantly, he did not have any red flags for malignancy like fever, sweats, weight loss, lymphadenopathy, etc. The past history, he just had some urticaria and recurrent nosebleeds needing cauterization. He was born in Pakistan but came to UK at the age of 1, and he was fully immunized. His medication history was unremarkable. However, there was a significant family history. Although he was born out of a non-consanguineous relationship, there was a strong family history of lupus. His his half sister and cousin on father's side both have a diagnosis of lupus. On examination, he had symmetrical periorbital edema with no erythema, no itching, nothing at all. He interestingly had very mild pitting ankle edema. I really had to look very hard for that, which was slightly more on the left side, but it is by no means what one would expect in nephrotic syndrome, where you get solid pitting edema. He also had some erythematous vasculitic spots at the tips of his toes, which actually had not been picked up before. So if you look, and I'll show the pictures of that later. He didn't have anything else like lymphadenopathy or a scrotal edema or something. His joints and muscle strength were normal, and systemic examination was normal. Investigations showed features of lupus. So he had a DCT positive hemolytic anemia. His complements were very low. His ANA and double-stranded DNA was strongly positive. Interestingly, his inflammatory markers were normal, ESR and CRP normal. The pattern one would expect in lupus is high ESR with normal CRP. His antiphospholipid antibody screen was negative, and his vitamin B12. So when you get somebody with lupus with low vitamin B12, you have to think about autoimmune pathology. So we did send for anti-intrinsic factor antibodies, which came back as negative. So these are the lesions I'm talking about. Can you see those red spots at the tips of his toes and at the bottom of his toes? And you can also see some subungual discoloration, which is an extension of this. So this kind of vasculitic spots can be a classical feature of lupus. So we use the SLIC criteria for the diagnosis, and he clearly fit in the bill because he had chronic cutaneous lupus, hemolytic anemia, thrombocytopenia, ANA, double-stranded DNA, and low complement. So he had 6 criteria. We only need 4 for a diagnosis of lupus, and it was very clear at that stage that his diagnosis is juvenile lupus. We did a bit of research about this periorbital edema because it is an unusual symptom in a patient with lupus. So literature says that ophthalmological symptoms of lupus or signs in lupus are not uncommon. Even up to 1/3 or 1/4 of patients can have that. But isolated periorbital edema is extremely rare. It is described as a presenting feature in as low as 0.1%. And most of those studies were about adult patients. And even in patients who present with periorbital edema, most of the time it is because of cutaneous lupus, where it's usually associated with erythema, crusting, blepharitis, etc., which can be confirmed on biopsy. But he had no skin changes whatsoever. Hypothyroidism also can sometimes contribute to periorbital edema. But interestingly, isolated periorbital edema with no skin changes at all can still be seen in lupus, although it's exceedingly rare. And some of these patients came actually reported from Asia, and curiously, at least a handful of them had associated pericardial effusion. So we were a bit worried whether this boy is going to have that. So what happened in clinic? I explained the diagnosis, showed them the criteria. This is what it is. It did not come as a big shock for the family because they already knew about this condition. And as a part of multi-system screen, I arranged for echo and lung function as outpatient. And I wanted to start him on treatment straight away, IV methylprednisolone. But I wanted to check with the hematology colleague just to make sure that they were not planning to do a bone marrow, because if they were planning to do a bone marrow, I would have had to defer my treatment until they did it. And they were happy for us to go ahead. But even before we could start treatment, he got admitted. So this, I think, was on a Thursday, and he came admitted on the following Monday with new symptoms. So he said he now having breathlessness on exertion. And there was one or couple of episodes of vomiting altered blood with dark stools. Now that got us panicking whether this is the ITP playing up. But then it was obvious from the history that this is probably swallowed blood following epistaxis. So we didn't come across as a primary GI pathology. He continued to have worsening fatigue and musculoskeletal pain and on and off fever. On examination, his obs were fine, so that is good. He was not tachycardic, tachypneic, or hypoxic to suggest that there was any cardiac or lung involvement. His periorbital edema persisted. Apart from that, there was nothing much. However, he did have tenderness over the right hypochondrium, which made me slightly uncomfortable because it did not quite fit into the picture. So we put him on antibiotics and blending blood cultures because he was having fevers. I brought forward the echo given the evidence we had in literature, however kind of minimal it was, and he actually turned out to have a moderate sized pericardial effusion. Without any delay, we started him on 3 days of IV methylprednisolone and switched to oral prednisolone with PPI cover. He was started on hydroxychloroquine. I arranged for an ultrasound mainly because of the concern about the right hypochondrium, but that actually threw up a surprise. Although there was no splenomegaly, he had multiple peripheral wedge-shaped hypodensities suggestive of infarcts. Now that stumped us a little bit. Why should he have splenic infarcts? And how dangerous is that? Should we do something about it? So we checked with the pediatric surgeons. They said because he's asymptomatic, we would just do nothing at this point. But more worryingly, his platelet count had dropped down to 6,000 from 66,000, despite methylprednisolone. And that is something which we do see in lupus. Thrombocytopenia in lupus can be refractory to steroids, and we may almost have to give IVIG. So he had IVIG straight away. We didn't delay for that. So he had 2 more days of methylpred and then oral pred. And the team felt that because he has got multiple systems affected, we should probably put him on cyclophosphamide for induction. Now, the family declined it outright because it's not unusual in these family groups. When you bring about the topic like infertility and hair loss, they are very uncomfortable. So the hair loss you see in rheumatological doses of cyclo is very minimal, nothing like what you get in chemotherapy. But despite that, they had reservations. So we chose MMF and we were going to start him on MMF. So then again, we did a bit of literature of how lupus can affect spleen. So I have seen lots of patients with lupus with splenomegaly, and it could be because of lymphoid hyperplasia, because generalized lymphadenopathy is not an uncommon presentation of lupus in children, not adults, but children. And it could be because of lymphoid hyperplasia, or it could even be because of hemolytic anemia. Splenic calcification has been described. Very, very rarely you can get a spontaneous splenic rupture like you can get in infectious mononucleosis or malaria. And then coming to splenic infarcts, they are exceedingly rare and the reports are almost exclusively from adults. But what are the causes of splenic infarct? The commonest cause is if they are positive for anti-phospholipid antibody, and he clearly was negative. So the theory is that this probably is a low-grade vasculitis that has triggered it, but he had no symptoms whatsoever without that. So what happened? So we put him on IV methylprednisolone, switched to oral prednisolone. His fevers had settled. He was feeling much better, and we were about to send him home when he started spiking temperature, and was very high temperature of 39, usually continuous temperature. We could not see any focus of infection clinically, nothing in his ENT examination, or there's no focus, no pneumonia, no chest infection. And he was not massively immunosuppressed anyway. He had just had 4 or 5 doses of steroids. But more worryingly, the CRP and ferritin started going up and his platelets started coming down. So after IVIG, his platelets had gone up to 50,000 and they start dropping down. So we did extensive screen for investigation, blood cultures and viral PCR. They all came back as negative except for weakly positive EBV. So what are the differentials we should consider in a patient who has got falling counts and high temperature and with rising CRP and ferritin? Obviously, infection needs to be considered, but the one which was really concerned about was macrophage activation syndrome. Now, we know that MAS is not an uncommon complication of systemic onset JIA. I'm just trying to pass on a message that it can be a part of other rheumatological conditions, especially lupus and JDM. Now, the question is, if it is macrophage activation syndrome, is it lupus driven or is it because of an EBV? But then the EBV titers, the microbiologist said, virologist said it's not significant enough to drive this. So then we calculated his H score. which is what we use to calculate the risk of MAS in patients with suspected MAS. And this probability came back very low at 1%. So this is a snapshot of its score if you're not familiar with that. So unfortunately, we didn't have any criteria for diagnosis of MAS in lupus. So we went to the EULAR 2016 criteria, but we need to keep in mind that this EULAR criteria is designed for patients with systemic onset GIA, not lupus. For the two mandatory criteria are fever and increased ferritin. He had both. Ferritin at that point was over 4,000. And you need two of the other three. He had low platelets, but the question was, is the low platelets because of lupus, immune-mediated thrombocytopenia because of lupus, or is this actually because of MAS? But given that his platelet count had gone up after IVIG and started dropping again, we put it down to possible MAS. And his triglycerides started going up. So he did actually satisfy the criteria. But then I'm just sharing you some of the challenges in diagnosing MAS and lupus. One of the basic criteria for diagnosis of MAS is pancytopenia. But now we know that the anemia in lupus patient can be because of immune hemolytic anemia, because of lupus. Similarly, thrombocytopenia can be immune-mediated thrombocytopenia. So how can we use that to make a diagnosis of MAS? That's tricky. Now, lupus also can cause coagulopathy, which too is common in macrophage activation syndrome. Another criteria are raised liver enzymes. And there are a number of causes for raised liver enzymes in lupus. It could be lupus hepatitis, it could be autoimmune hepatitis, or it could even be drug-induced, like, for example, if they are on methotrexate. And what about neurolupus? You get CNS manifestations as a part of macrophage activation syndrome, but you can get CNS manifestations also because of lupus. So the point I'm trying to get across is that macrophage activation syndrome diagnosis is challenging to make in a patient who has got a background of lupus. There is one paper that came, I think it was in the late 2000s, that specifically set out a diagnostic guideline for MAS in lupus. And I find this study really fascinating and helpful. But unfortunately, this has not been validated subsequently. So one of my trainees is currently undertaking a project for this. So he easily satisfied the criteria. He had fever, and you only need two of the following lab criteria. In fact, he had 4. So we were all fairly convinced that he's heading towards macrophage activation syndrome. He hasn't already got it. And you can hear that here CRP is climbing up, his ferritin kept climbing up, and his H score went from 1% to 25% probability of MAS to 50% probability within 48 hours. And this happened on a weekend. I'm sure you all appreciate that macrophage activation is not something which we can sit on. We just need to manage it aggressively. So these are one of the situations where you just treat and then ask questions. But then, even if when you have made a decision to treat the MAS, it comes with questions in lupus. So there's a two-pronged strategy you can use. One is to try to treat lupus aggressively as a driver of MAS, or try to treat lupus and MAS separately. The problem here is the medicines you use to treat lupus, namely cyclophosphamide or rituximab, do not work for macrophage activation syndrome. So we just need to treat them aggressively and make sure and hope that treating lupus will switch off the MAS. The other strategy is treating them separately. You give rituximab, cyclo, or whatever to treat lupus, and use anti-IL-1 blocker, which we have access to, fortunately, in UK, and anakinra separately to treat macrophage activation syndrome. We went for the former approach. So we gave him 3 more days of methylprednisolone. Because of his platelets plummeting again, we gave him a second dose of IVIG. Now, IVIG, the second dose had more significance because IVIG is one of the treatment arms for MAS. So the second dose was given not just for thrombocytopenia, but also with the hope that that would help with the macrophage activation. We gave him rituximab, but as you would know, rituximab usually takes about 6 to 12 weeks to start working. So you can't leave him on IV steroids until then. So what I went back and spoke to the family and explained that he clearly has a problem now. It's a life-threatening complication, and can we just use a couple of doses of cyclophosphamide in the interim? And the family agreed. So he had 2 doses of cyclophosphamide, and that worked perfectly in tandem for rituximab to start working. And he had an excellent response. So he was back at school in 2 weeks. His inflammatory markers normalized. his double standard DNA had come down to about 1/4 and his complements were normalizing. So he had a complex presentation. So what were the challenges we had in this case? One was the extremely unusual presentation, isolated periorbital edema with nothing else. The second was intractable thrombocytopenia, which is not unusual in lupus, and often we have to resort to IVIG. Chronic infarcts, we didn't see that coming. It's actually serendipitously picked up, but then obviously that made us think about what could cause this. And we still don't know, and we presume this is some kind of subclinical vasculitis. And the family decline in cyclophosphamide made it a bit more challenging, so we have to kind of work around with other medications. And I think I can highlight the importance of having an honest discussion with the family and explaining to them why we need cyclophosphamide. And actually, they were very sensible and they kind of agreed to do that second time round. And obviously, the challenges of diagnosing and managing macrophage activation in lupus. So I go on to another girl who was admitted about 3 weeks before I left UK, and she was being discharged as I was leaving UK.
Kishore, can I interrupt and ask a question?
Yeah, of course.
Why didn't you give Anakinra?
We did not give Anakinra. So the two options
I mean,
to treat macrophage activation.
SOJIA, they say that in mass, Anakinra life-saving. That's what they say.
So Anakinra is the gold standard in systemic onset JIA-induced macrophage activation syndrome. Whereas in patients with lupus-related systemic macrophage activation syndrome, there is no clear guidance. The two options are, what is the driver of macrophage activation syndrome? If it is lupus, treat the cause and MAS will go away, which is what we did. The second, because none of the medications that we use for lupus will switch off MAS. So if he had not responded to what we tried, we would have had to go down the Anakinra route. But we did not want to try it at the first option. So we gave him rituximab and cyclo. Yeah.
What did you say? None of the medications
that work for lupus work for macrophage activation. That is the problem.
Okay.
So which is why one option is to treat lupus aggressively and presume that that will switch off MAS, which is what we did. The other option is treat lupus separately and MAS separately. Give rituximab or cyclo or whatever we want to give for lupus or MMF, and give Anakinra for macrophage activation syndrome. So we wanted to try the first strategy first, and if he still had not responded, we had warned the family that we'll be going down the Anakinra route. But thankfully, he did not have to go down that route. But sometimes you will have to make that decision. Did I answer your question, madam?
Okay. Thank you.
Yeah. So this girl had, again, if you find that a lot of lupus patients come with very non-specific symptoms. So she had the same general malaise, fatigue, sleeping for 15, 16 hours a day, too tired after school. But the other important thing, she had really significantly swollen ankles, which they initially thought was actually arthritis, but it was creeping up. It was obvious that it was more nephrotic kind of swelling. Some joint pain and rash. On examination, she clearly had a malar rash, but she had extensive mottling of her arms and legs, livido reticularis, which when you see that in lupus, you should always think of anti-phospholipid antibody syndrome. She had pitting pedal edema almost up to mid-shin. But the thing that worried us the most is bluish discoloration of some of her fingers and toes. Can you see that clearly? So if you look at the bottom picture, the tips of 3 fingers are very blue, and you can see the right little finger being blue. And for her foot, it was not just blue, but she had a gangrenous tip of that toe. That made us very concerned, because that is potentially, if you don't treat it, she could go down to amputation, which is a big problem. She all had significant swelling and move pain of her fingers and toes. But when I examined her, I felt that it was more because of the ischemic fingers than because of arthritis. The other thing that made me worried that she had extremely low mood. Her affect was really worrisome. The moment you say something, she started crying. So you can expect a 14-year-old teenager who has just been given a big diagnosis to be depressed. But she was really out with what we would expect. She would be constantly crying and refused to talk to people, and she had really withdrawn, and mom was very concerned. So was I. When you see somebody with suspected lupus who has got neurological symptoms, or who has got psychiatric symptoms, think about neurolupus. Her systemic examination was normal, and her blood test actually confirmed the diagnosis of lupus. So hemoglobin was 68, and we know why, because she was DCT positive, and that too with cold agglutinin. Now, immune hemolytic anemia is common in lupus, but cold agglutinins are extremely uncommon. But she had immune hemolytic anemia with cold agglutinins, which was well. She had the typical combination of very high ESR of 145 with relatively normal CRP. Again, I reiterate, when you get very high ESR more than 100 with normal CRP, always think of lupus. But what worried us was her renal function. Her urea was 16.4, which is like 2 times normal, and creatinine was 136 millimoles, but we do in millimoles, which is again double. Her GFR had dropped down to around 45 to 50 and should be more than 90. So creatinine had almost doubled, although her urine protein creatinine ratio was actually relatively normal. So there were two concerns, or in fact 3 concerns. One was her kidneys, one were the fingers and the toes, and the third thing was her mood. And obviously on the right side, you can see all the investigations confirmed lupus. She had a strongly positive ANA, very low C3, C4, very high double standard DNA. Interestingly, we knew the cause of her blue tips because all 3 antiphospholipid tests came back as positive. She had weakly positive lupus anticoagulant and strongly positive beta-2 glycoprotein and anti-cardiolipin antibodies. So when we see somebody with blue toes or fingers, always think about antiphospholipid antibody syndrome. It could be primary or secondary. So I remember seeing one girl with this problem while I was working as lecturer in Thrissur. But it's not very common, but always think about that. Another differential diagnosis we should consider is ANCA vasculitis. We have had 2 young people who have had ischemic fingers because of ANCA vasculitis, but for her, ANCA was negative. We did some infection screening to think about the causes of cold agglutinins like streptococcal and mycoplasma. They all came back as negative. So she clearly had lupus. The ones I have marked in blue are definite. So she has got acute cutaneous lupus, renal involvement, hemolytic anemia, ANA, double standard DNA, antiphospholipid antibody, and low complements. She possibly has arthritis. I'm not sure. I felt it was because of ischemic fingers pain. We don't know whether she has got serositis unless we do investigations. And my worry was because of her low mood, is she also having neuropsychiatric lupus? So as a part of systems, we undertook echo, which showed a small pericardial fluid, chest X-ray, which showed a small pleural effusion, renal biopsy. So a gold standard is if a patient with lupus comes back with poor GFR, do or a proteinuria, always better to do biopsy. So she had class 4 lupus nephritis. And the Doppler scan confirmed that her big arteries, the radial arteries and ulnar artery and the ones in the lower limb were all intact, which means that this is actually a peripheral arterial or capillary thing. We did an MRI of head to make sure there is no neurolupus, and thankfully that came back as normal. So what did we do? Obviously, she was fluid restricted as advised by the renal team and stopped on furosemide. She had 1 packed cell transfusion. Now, the problem with giving transfusion in patients with cold agglutinin is that we need to use a blood warmer to give it, because otherwise it would agglutinate. So we had to get the blood warmer in the middle of the night to give some warmed up blood. And she was seen by the vascular surgeons because of the concerns about the fingers. And they, on their advice, we started her on treatment dose of enoxaparin and iloprost infusion. So iloprost is a prostaglandin analog. I think it's a prostacyclin analog to be used. It is used in rheumatological conditions with peripheral vascular disease, especially people with systemic sclerosis. It is also used for pulmonary arterial hypertension. She also had compression stockings because she was at high risk for deep vein thrombosis. In terms of lupus-specific treatment, we started her on methylprednisolone and moved her to oral steroids. We started hydroxychloroquine, and we unanimously agreed that she needs cyclophosphamide because she had kidney-threatening disease. But what happened after that? She developed melena. Now, she had lots of risk factors for melena. One is she's on high-dose steroids. Secondly, she's on prostaglandin infusion. And lastly, enoxaparin could perpetuate the bleed. So we stopped all of it and started her on double dose IV PPI and gave her another packed cell transfusion. But the following week, she actually turned the corner quite dramatically. Her renal function had normalized, her GI bleed settled, hemoglobin stabilized. Her fingers are still pretty much the same, and the vascular people said there's nothing more we can do at this stage. The black beetle will just gangrenously slough off. There's nothing to worry. That's the natural progression. Her mood actually turned out to be much better. She's smiley and chatty now. And we did do a lot of literature search, which shows that rituximab actually works well for cold agglutinins in lupus as well as ischemic fingers. So we just added, after I left UK, we have given her the first dose of rituximab. So that's another complex course of lupus. And I mean, the first boy demonstrated that he looked absolutely well when he first came in, and how quickly lupus patients can go downhill and how much we need to be on our toes to manage these patients. This is a more straightforward girl who I saw about 10 years back. She was again a GP referral. The story is that, again, she has got intense fatigue and she's not herself since what looked like a viral infection in January. And this is a girl who used to do like 2 to 3 hours of kickboxing every day. For the last week or so, she can't do any, or last month or so, she can't do any kickboxing, and she's just coming back home and just going to bed straight away. So they were very worried about her energy levels. She also started complaining of pain in joints in April, so we are seeing in June. And in May, she was in ED, seen in emergency department with chest pain. So they did an ECG and X-ray, which was normal, and she was reassured and sent home on antacids. But blood test at the time showed a hemoglobin of 8. So they started her on iron, but they found that despite 4 weeks of iron, her hemoglobin has actually dropped down to 6.6. So that was a matter of worry. And she was also complaining of a central chest pain and shortness of breath for the past week. She had some weight loss. There's no significant past history. There is a strong history of autoimmune conditions in the family. Mother had hypothyroidism and grandmother has rheumatoid arthritis. Her examination was pretty much unremarkable, except that she was quite pale, which one would expect with the hemoglobin of that. She was tachycardic, but the joints were normal, and the systemic examination was pretty much normal, except for a functional murmur. So investigation showed that she clearly had low hemoglobin, and her ESR was very high with normal CRP. So that is when lupus came into the picture. But when they did her ECG, they found that she has low voltage QRS complexes. So the question then is, what investigation would you do next? We did a simple one, chest X-ray, and this is what it showed. She had significant pericardial effusion. You can see a globoid heart there, suggestive of pericardial effusion. So the differential diagram, that is the point at which I was called. And when I looked at the ESR and CRP, I know which way you are heading. The differences we would consider is it post-infective like strep, it could be viral myocarditis, although she's not the right age group for that, and whether this is hypothyroidism or whether this is rheumatological. So she had immune hemolytic anemia, which is why it did not respond to iron. The complements were low and antibodies were suggestive of lupus. So coming back to lupus, I mean, the first thing I need to say is it's an extremely rare condition. All the things we manage are, the commonest condition we see is JIA, which is seen in probably 1 in 1,000 patients. But then we still cover a large population. So we do see about 500 patients with JIA and our care. So it is still rare in general population. Only about 1/5 of all lupus present in childhood, but there is a problem. The lupus that we see in children are generally tend to be more aggressive both in presentation and in clinical course, which means that we need to be aggressive in managing them. The classical age group is teenage, usually after 10, 11, 12 years of age. As with most rheumatological conditions, it's commoner in girls, but post-pubertal girls, it is much more common in girls. It's about 8 to 10 times more common. Now, why do I bring in ethnicity? It's very important when I work in a multi-ethnic society for me to be aware of this. It's clearly more common in African, South Asian, and Chinese ethnicity. So if you look at our JIA patients that I see back home, 95% of them are white British. Whereas if you look at the lupus patients, 60 to 70% of them are belonging to either of these three categories: African, South Asian, or Chinese. There is a clear ethnic predisposition for this. The first things I remember when I was a medical student reading about lupus is the butterfly rash. We need to be very clear that butterfly rash is not a classical presenting symptom in children. Only about 50% of our lupus patients, or if you look at the literature, have this malar rash. So if you look for the rash to make a diagnosis of lupus, you probably have lost some time there. Why are we worried about lupus? Lupus because the risk of multi-organ involvement, which is particularly worrisome in children because they have a much higher risk of renal disease when compared to adults. One important symptom which we see is fatigue. Now, fatigue, everybody can get fatigue, but the fatigue is so profound that somebody who is doing 3-4 days of sports in a week ends up sleeping for 13 to 14 hours a day, which is very unusual. So that kind of fatigue is common in these patients. What about pathogenesis? This is a common slide you would see in any condition, JIA, JDM, lupus. So there is definitely a proven innate genetic susceptibility. And in those individuals, it gets triggered by one of the environmental stimuli. Now, it could be sunlight, it could be viral infections, especially EBV, or it could be drugs. Very rarely drug-induced lupus. So this is the general picture. And that then leads to an autoimmune storm where you get lots of antibodies. Presentation, if you look at textbooks, the classical presentation of lupus in children is arthritis, rash, and fever. However, I would like to say categorically that probably only about 25% of our patients have this presentation. A lot of patients have multisystemic presentation, or they have a single system that would make you worried about lupus. I think I would say probably about, again, more than 1/4 or 1/3 about our patients come to the renal ward with acute kidney injury. They can go to a hematologist with an ITP or immune hemolytic anemia. Sometimes they can have cirrhosis. I remember this girl about, again, 10 years back who ended up in the respiratory ward. She was being treated with antibiotics for pneumonic effusion. But when I looked at her bloods, her ESR was 130 and CRP was 5, and you don't get that in pneumonia. So then she was referred to us, and we had low complements and strongly positive antibodies. So they can end up with cirrhosis. Thankfully, neurological lupus is not as common in children when compared to adults. Then you can have this, like the girl I discussed, vascular presentation with ischemia, and sometimes it can be just non-specific like VUO. So this is the ACR criteria that we used to use, but we have kind of slowly moved away from that. It's more of an adult-centric criteria, and we use the SLIC criteria for the diagnosis of lupus, which includes 2 compartments. You have 11 clinical criteria and 6 immunology criteria, and you need 4 in total, at least 1 from each group. Couple of things to remember is, if you have counted thrombocytopenia as a clinical criteria, like in this boy, you can't use thrombocytopenia again on the right side. Or sorry, so DCT, if you've got immune hemolytic anemia, if you include that in the clinical criteria, you can't use that in the immunological criteria. That's the only thing to keep in mind. Examination, the things I would look for in a patient with suspected lupus: extensive skin investigation. So look at that. These are the kind of rashes you can get. So the malar rash that you get in lupus doesn't have to be a continuous rash. It can be non-continuous spots. Sometimes I've seen patients with what look like acneiform lesions, which are just confined to a malar region. That itself can suggest lupus. You can get these red spots like Osler's nodes and Janeway lesions, like you get in infected enterocolitis. You can get similar lesions, which is signify vasculitis of the palms. You can get classical discoid lupus, which definitely is more common in adults than in children. Other thing we do is nail fold capillaroscopy. On the left side, you can see uniform, symmetrically arranged nail fold capillaries. On the right side, you can see a distorted pattern where it is disrupted and you get really dilated, loopy capillaries. This is more specific for systemic sclerosis, but you can also get that in dermatomyositis and lupus. Going back, and then some of these patients can have Raynaud's. That can be a significant manifestation, and alopecia can also be a feature of lupus, especially alopecia areata. I would definitely look for pallor, mucocutaneous bleeds to look for evidence of thrombocytopenia, edema, nephrotic syndrome, lymphadenopathy. Now, it's important to remember that lymphadenopathy is actually a significant presenting manifest. I remember at least 2 patients who went to our hematology and oncology colleagues for bone marrow biopsy, and lymph node biopsy who turned out to be lupus in the past. They may have mouth ulcers. Obviously, you may have hepatosplenomegaly and ascites if they have got nephrotic syndrome. We need to do a thorough musculoskeletal examination. They can have myositis, so muscle strength testing is important, and the neurological examination. So investigations, full blood count, mandatory, because you can actually get pancytopenia in this patient. You can get immune hemolytic anemia, thrombocytopenia, and lymphopenia, which is more common than leukopenia. ESR is mandatory. Usually you get very high ESR with normal CRP. If the patient is anemic, definitely we should do a DCT to look for the cause of anemia. I always would undertake a coagulation screen in these patients, especially lupus anticoagulant, meaning obviously would do renal function, liver function, muscle enzymes. ANA, double standard DNA, and ENA are very important. So ANA is very sensitive, double standard DNA is more specific, whereas ENA can predict what system is likely to be affected. I'll show that in a moment. And obviously, I said, please check for antiphospholipid antibodies. Complements are extremely useful in the diagnosis of lupus. They form a part of SLIC criteria. If you do their immunoglobulins, you find that they have very high IgG levels, which is because of all the antibodies they have. Every single lupus patient needs to have a urine protein check. Whatever is the local method, 24-hour protein is absolutely fine. We have moved away from that because we just use PCR these days, and preferably on an early morning sample. Thyroid function and ATP are important because the commonest autoimmune association is anti-thyroid peroxidase antibodies leading to hypothyroidism. Chest X-ray, I would always do a baseline chest X-ray and as echo and lung function. Some are not all our patients, but most of our patients get seen by ophthalmologists at least once because they have changes like cotton wool spots in the back of eyes. So this picture gives you an idea of which antibody predicts what. So if you have strong anti-ribosomal P or antiphospholipid antibody or anti-SM, always worried about lupus. Anti-LA and anti-Rho predicts skin involvement, hematological manifestations, and joint involvement and vascular involvement. Kidney, the antibodies that are specific, the most important one obviously is double standard DNA. You can get C1q antibodies and anti-nucleosome antibodies to predict kidney disease. And when patients have really bad Raynaud's, now I don't know whether we see Raynaud's in Kerala at all because our weather, we only have hot weather. But if you see somebody with Raynaud's in Kerala, I would be really worried whether they have lupus. And those patients are likely to be anti-RNP positive, and they may even go on to the mixed connective tissue disease phenotype. Differential diagnosis, always ask for drug history. One of the things I've seen in patients with nephrotic syndrome, or especially steroid-dependent nephrotic syndrome who go on to levamisole. So levamisole has, I remember levamisole can sometimes trigger this. It can also cause anti-vasculitis. Anti-epileptics. We recently had a patient who had ethosuximide-induced drug-induced lupus. So always take a careful drug history. If you get a patient with lupus under 5, or if they are ANA negative, always think about monogenic lupus. It's a different discussion in itself. I just want to let you know that there are certain types of lupus which are monogenic, and a couple of common things are complement disorders and type 1 interferonopathies. Sometimes patients, when you get lupus patients with hepatitis, they can actually be autoimmune hepatitis because that can also cause false positive ANA and double standard DNA. So this is a very simplistic picture of looking at how to manage lupus patients. Every single lupus patient will need systemic steroids, high dose corticosteroids. So we tend to give them 3 to 5 days of IV steroids and then switch them to oral. Hydroxychloroquine is absolutely mandatory. It is clearly shown beyond doubt that improves survival and minimizes the risk of organ involvement. If they have antiphospholipid antibodies, they need to go on to aspirin, and every one of our patients is advised sunscreen because one of the biggest triggers of cutaneous lupus is sun. Now, if they are on the mild end of the spectrum, the options are methotrexate, azathioprine. I am personally not a big fan of azathioprine for induction. I use it for maintenance, but I'm not a big fan. If there is especially joint involvement, methotrexate is a good choice. If they have got moderate disease activity, we tend to go with MMF or rituximab. If they have organ or life-threatening lupus, we always use cyclophosphamide plus or minus rituximab. Now, some of the new medications which have come up quite helpful in management further is one is belimumab, which has been, I'll discuss about that later. It's been approved for use in children over 5 years of age. It is given as 4-weekly infusion. So if you have moderate or severe lupus that has not responded to MMF or methotrexate, belimumab is a good option. Calcineurin inhibitors, especially voclosporin, has emerged as a very useful adjunct in the treatment of lupus, especially lupus nephritis. But most of those studies are adult-based. So what is the principle of management? Induction. So we control disease activity with high dose immunosuppression. Maintenance. We try to control disease activity by minimizing the flares by using less intense immunosuppression. In the middle of all this, especially at presentation, plasma exchange may have a role sometimes in kidney disease or neurological disease. This is a list of medications. I'm not going to go through that. Essentially, IV methylprednisolone, cyclophosphamide, rituximab, MMF, methotrexate, and azathioprine plus IVIG for patients who need it. Now, British Society for Rheumatology has recently come up with a guideline for management of lupus. So I'll just briefly touch upon that. But before that, a quick slide on what the future offers for these patients. So belimumab is now approved for use. I think it is approved in India. Am I right, Geeta Madam? Because the IAP guideline, I saw it very briefly and it mentions about belimumab. Is that applied, approved here? I don't know.
Yes, it is. It is. Some
It's
are
a
using
very,
it.
very useful adjunct. If patients fail MMF, that's a very good medication to run. It works a bit similar to rituximab. It's actually a B lymphocyte stimulator specific inhibitor. And there was this Pluto trial which really showed that it works. So it is particularly good for joint disease, for skin disease, and patients who have got loads of antibodies. Now, obinutuzumab, again, is similar to rituximab. It's a humanized anti-CD20 monoclonal antibody. So obinutuzumab has got role only in lupus nephritis. So in patients who have got isolated lupus nephritis, we can use that along with MMF. But we need to take into consideration they have got neurolupus alongside or severe immune hemolytic anemia or something. We may have to use at some other agents. If you look at the study on lupus, there is definitely evidence that there is high interferon signatures in these patients. So anti-interferon therapy is coming up now. JAK inhibitors are used because they work on the JAK-STAT pathway with reduced interferon signatures. Anifrolumab has been approved for adults. I don't know whether it's available in India now, but it can be an adjunct. But then most of the evidence is coming from adults. There is clear evidence that it reduces disease activity in moderate to severe lupus in adults. Obviously, the big thing now that's coming is CAR T-cell therapy. So the CAR T-cell therapy, the first ever series of CAR T-cell therapy in autoimmune diseases was in that original study published in NEJM, which was on lupus, but that is adult lupus, a series of 8 patients. So what does the BSR guideline say? It says mild to moderate, we give methotrexate, MMF, or azathioprine. If the patient is in children over more than 5 years who are not responded to above, belimumab is a good option. It really works well for skin, MSK, and immunologically active disease. So there are lots of patients we have who clinically get better, but they have persistently high double-stranded DNA and low complement. So this is particularly useful in that group. If it's a moderate to severe lupus with no renal involvement, rituximab definitely is the first choice. If there is severe thrombocytopenia, IVIG is an option. But for neuropsychiatric lupus, it's always cyclophosphamide, rituximab, or a combination. Similarly, for organ/life-threatening non-renal lupus, you still use these things. So the maintenance therapy, as I said, you could go on to any of these. So cyclo and ritux are definitely options that we would use for organ-threatening or life-threatening lupus. For milder ones, you can use methotrexate, MMF, azathioprine, and belimumab. Lupus nephritis, I think I'm probably exceeding my time, but I'll very briefly go through it. One important thing to remember that it is much more common than renal involvement in adults. It's about 40 to 80% in children, almost double the risk in adults, which is 20 to 40%. Gold standard for diagnosis of lupus nephritis is biopsy. If a patient comes to you with nephrotic picture or proteinuria or abnormal GFR or renal function, it will be a good idea to undertake a renal biopsy because the extent of kidney involvement then dictates the treatment. The poor outcomes on biopsy are chronicity and activity. And this is the the criteria for lupus nephritis. So things to remember is there are 4 letters there, A and C. A means active, C means chronic, G and S. G means global and segmental. So if a patient has got a segmental disease with activity, it's probably easier to treat than somebody has got a chronic global disease. I'll just quickly move on to this. So what are the treatment options we have? If it's class 3 or 4 nephritis, these are all options: MMF, obinutuzumab, voclosporin, belimumab. And it is advised that we give a combination immunosuppression, 2 of them. So we could use MMF and belimumab in such patients. If it's an organ-threatening lupus nephritis, again, we back to the old question, cyclophosphamide plus or minus rituximab. Now, if it is a class 5 disease, calcineurin inhibitors, clearly either cyclosporin, voclosporin, tacrolimus have a role on top of MMF. What are the biomarkers? Every time you see a patient with lupus nephritis, please check serum creatinine, urine protein to creatinine ratio. Immunological double standard DNA and complements are extremely helpful in monitoring patients with lupus. There are some newer urinary agents which are not in practice at the moment. Prognostic factors, again, if you have low EGFR representation, especially needing peritoneal dialysis, hemofiltration, hemodialysis, etc., they have a definite high risk of chronic kidney disease. These are some of the risk factors we find. It is worse in boys, non-white population, hypertensive, people who have nephrotic syndrome presentation, and with phospholipid antibodies and chronicity on biopsy. But thankfully, CKD in children is only seen in about 3 to 4% of all lupus patients when compared to adults. So we are doing something in that group. This is about lupus. So lupus treatment is not just about medicines. It is essentially a multidisciplinary and multi-professional attachment. So there are patients who would need physio input, there are patients who would need psychology input, there are patients who would need nursing input to give them injections and stuff like that. Patient education is an integral part, and that would include things like contraception, because many of these medications which we use, it's probably less of a problem in India because I think pediatrics here is probably 12 to 14 years, whereas it's much more of a problem for us because we see patients up to 18. And sometimes we get a phone call, or nurse gets a phone call saying that this patient has just tested positive pregnancy test, and then we don't know what to do because many of these medications have not been proven to be safe in pregnancy. I wouldn't say they're teratogenic, but there is no enough data to say that they're safe. Lifestyle modification, alcohol, all these things, and even in terms of diet, because many of these patients are on systemic steroids that can add to their weight. Family planning is important. Many of these patients have absence at school and they get bullied and everything. So we need to liaise with school and college and let them know, especially in terms of sports and other things. And obviously, many of these patients do need psychological and emotional support. And one important part of care of lupus is transition, because we just see them until 16 or 18, whatever the local protocol is. They have a whole life ahead of them. And we need to make sure that the adult rheumatologists who takes over their care are fully aware of the patient, not just the condition. Complications, you can get end organ damage, especially the commonest is renal. You can get complications of treatment like immunosuppression leading to injections, steroid side effects. Sometimes they can get transient diabetes, which we may have to manage until you get down on the steroids. Growth and puberty can be a problem. They can have psychosocial issues. And there is definitely evidence that lupus increases the cardiovascular morbidity in adulthood. There are lots of studies which has proved that. Follow-up in lupus patients, always do check their growth. Anthropometry is important. Complements, C3, C4 antibodies 6 monthly, and disease activity tools are there, which you may choose to use. Ideally, it will be good practice to use them. And how often do we see them? We see them 2 to 4 weekly until they are in remission. And once they are in remission, we go 3 monthly. And we always have a patient hotline which they can ring and let us know if the child develops a fever or an infection or whatever. I'll just sum up with a couple of slides on ANA and double standard DNA. I'll always get asked this question. Now, your ANA positivity, how significant it is, depends on 3 things. One is type of substrate. That's not an issue anymore because I think all the centers now use HEP2 cell lines. That's not a problem. The most important thing would be the titer of the results. So if the ANA comes back as 1 in 40, I won't worry about it because 1/3 of the general population, 33%, can have that. But with increasing titer, you find that it is more likely to be true positive. For example, only about 1/6 of the population have it once it's 180. But once it go up to more than 320, it's highly likely to be significantly positive. And sensitivity, it's a very sensitive test. It's not a specific test. And it is especially sensitive for lupus and scleroderma, where the sensitivity is between 80 to 90%, even up to 100%. It can also be seen in JDM and Sjogren's syndrome. But the specificity is generally low. So you can also get ANA in JIA, which has got no diagnosis signal. The only thing is it increases the risk for uveitis. Whereas, just to summarize, it should only be requested if you are suspecting a rheumatological condition. What is the role of ANA in the diagnosis of lupus? A negative ANA is an important sign to rule out lupus. So if somebody calls me saying that I'm worried this patient is lupus, I ask them to do an ANA. If the ANA is negative, it's highly unlikely that the patient has got lupus. And it is also seen in patients with scleroderma. And the important thing to remember is this has got no relation with disease activity. So once you have treated a lupus patient, so in all the patients I mentioned, when they go into remission, if you check their ANA, it will still high. It will still be high. It has got absolutely no correlation with disease activity. Now, double standard DNA is on the other end of the spectrum. It is very specific, 97% specific for lupus. There are not many conditions which gives you a false positive double standard DNA. The one I can think of is autoimmune hepatitis. You can get false positive double standard DNA, but otherwise it's very rare. And the other difference is that it can give you information about disease activity, which means that if you have treated a patient adequately, the double stranded DNA antibodies should come down. So it's a very useful prognostic outcome measure. I think, sorry if I've exceeded my time, but this is where I work at the moment, Nottingham University Hospital. And I thank you once again for giving me this opportunity. I'm happy to take a few questions. Thank you.
So thank you, Kishore, for that very informative discussion on lupus. I mean, areas are really gray for us sometimes, when we encounter real cases, possibly because the investigation modalities are not that, what should I say, specific. Okay. So can we discuss a case on lupus?
Yeah, of course. Yeah.
Okay. So Dr. Roshni, she's going to present a case on lupus. It's currently admitted in our hospital. Roshni, can you start?
Yes, ma'am.
Dr. Roshni is a junior resident, first year junior resident, Kishore.
Okay. Hello, Roshni.
Good afternoon.
You can keep it short, Roshni, as we are slightly... Okay.
Can you please enable sharing, screen sharing? Sir, I can't share my...
ആണോ
പറ്റുന്നില്ല.
പറ്റുന്നില്ലേ? കോസ്റ്റ് ആക്കിയിട്ടുണ്ടല്ലോ റോഷ്നിയെ. ഒന്ന് ക്ലോസ് ചെയ്ത് ഒന്നുകൂടെ ഒന്ന്
ഇല്ല, പറ്റുന്നില്ല സർ.
ഹലോ റോഷ്നി,
ലീവ് ചെയ്തിട്ട്
പറ്റുന്നില്ലേ? ആ 3 ഡോട്ട് കണ്ടില്ലേ, മോർ എന്നുള്ള, അതിൽ ക്ലിക്ക് ചെയ്യുമ്പോൾ
അതില് പാർട്ടിസിപ്പൻസിനെ എനേബിൾ ചെയ്യുന്നില്ല എന്നാണ് കാണിക്കുന്നത്. ഞാൻ ഒന്നുകൂടെ ലീവ് ചെയ്തിട്ട്
ഒന്ന് ലീവ് ആയിട്ട് ഒന്ന് ജോയിൻ ചെയ്യോ? ഞാൻ രോഹിണി അല്ലക്കോ റോഷിനി കാണുന്നില്ല.
മാറിപ്പോയോ?
ആ രോഹിണിയാണല്ലോ. റോഷിനിയുടെ പേര് കാണുന്നില്ല. റോഷിനി
Roshni,
ഞാൻ
are
രോഹിണിയാണ്.
you there?
റോഷിനിയുടെ പേര് കാണും. ലീവ് ചെയ്തെന്ന് തോന്നുന്നു മാഡം. ജോയിൻ ചെയ്യാൻ വേണ്ടിയായിരിക്കും. എനിക്ക് റോഷിനിയുടെ പേര് ഇതിന്റെ അത് കാണുന്നില്ല.
ഒന്ന് വിളിക്കോ?
അല്ല, കയറുമായിരിക്കും മാഡം.
ആ,
റീജോയിൻ ചെയ്യാൻ വേണ്ടി എക്സിറ്റ് ചെയ്തായിരിക്കും. നോക്കാം മാഡം, വരുന്നുണ്ടോ നോക്കാം. ഇപ്പൊ റോഷിനി കയറി. റോഷിനി ഞാനിപ്പോ ഹോസ്റ്റാ. ഇപ്പൊ ഒരു മിനിറ്റ്. ഇപ്പൊ അയക്കാണ്. ഇപ്പൊ ശരിയാക്കാം.
ആക്ച്വലി രോഹിണി ചേച്ചിനെ മാറി ഹോസ്റ്റ് ആക്കിയെന്ന് തോന്നുന്നു.
മാറി. ഇപ്പൊ റോഷിനി ആക്കിയിട്ടുണ്ട്. നോക്കിയാ ഇപ്പൊ ട്രൈ ചെയ്ത്.
പറ്റുന്നുണ്ട്.
ഓക്കെ.
Kishore, you're there, no?
Okay. I think my video is malfunctioning, so I'm sorry. I'm trying to switch it on.
It's okay. It's okay. It's okay.
I'll have to leave and come back. I don't want to upset this at the moment. So.
No, it's okay, Kishore. We can hear you, so that is okay.
Is the screen visible, sir?
Yes, it's visible. You can start. She can start, Kishore.
No problem.
Okay. Start.
Good afternoon, everyone. I'm going to present a case on SLE with lupus nephritis. Recently, a child was admitted in our hospital.
Are you sharing slides? I can't see anything.
Yes, sir. Sharing started.
I can't see it.
You can't see?
No.
We are able to see. Yanka കാണാലോ, Kishore.
Shall I just move, log out and come back?
Yes.
1 second. I've joined back, madam. Roshni, you can present.
Okay, sir. Good afternoon, everyone. I'm going to present a case on SLE with the lupus nephritis. Recently, a child, a 12-year-old girl child, came to our OPD with the complaints of abdominal pain for 8 days and headache on and off for 5 days and cola-colored urine for 2 days. She was admitted in March and on history of presenting illness. 12-year-old girl child apparently, prior to the onset of illness, developed abdominal pain 8 days prior to the presentation. Pain was colicky in character, localized to the epigastric region, occurring several times a day, non-radiating. She was initially managed at local hospital as gastritis and later referred here in view of persistent symptoms. History of headache on and off for last 5 days, throbbing in character involving left parieto-temporal region, not associated with vomiting and worsened by studying fasting. Complaints of cola-colored urine, gross hematuria for 2 days, sudden in onset, present throughout the stream, not associated with painful micturition or decreased urine output. And there is no history of any decreased urine output, no history of edema, no history of periorbital puffiness, no history of fever, no history of pyodermal lesion, no history of breathlessness on exertion or chest pain, no history of arthralgia, pallor or alopecia, no history of convulsions, psychotic behavior or cognitive decline noticed. Past history, child had a history of headache since 8 years of age, on and off, but not taken on any regular medication. One hospital admission was there at 5 years of age for left-sided headache. There is no relevant antenatal, natal, and postnatal history. Second child of a non-consanguineous marriage, 29-year-old mother, spontaneous conception, but there is one history of abortion. Natal trimester, first, second, and third trimester stages were uneventful. Postnatal period was uneventful. Developmentally normal child, good scholastic performance. Immunized till age. And family history, she's a second child. There is a history of migraine in maternal grandmother and history of hypertension in mother since 29 years of age. No other family history of any autoimmune, renal, or rheumatological illness documented. Gel physical examination, child alert and active, no pallor, cyanosis, jaundice, edema, clubbing, or lymphadenopathy noticed. Vitals, pulse rate 82 per minute. BP was on a higher side, 122/80, 95 to 95 plus 12 centile. Respiratory rate 18 and saturation was normal. SMR staging, Tanner stage 2 to 3. Head size, shape, eyes, ears, nose and oral cavity was normal. She was having an obese habitus with acanthosis nigricans present, and there was a swelling of size 3 cross 3 centimeter, which was non-erythematous present in right forearm. No oral ulcer or no facial rashes. Anthropometric evaluation showed obese characteristic, weight between 75th and 90th centile, and BMI also 24.6, obese. Systemic examination, respiratory system, normal examination, bilaterally symmetrical chest movement and work of breathing normal. Cardiovascular, no tachycardia, no gallop rhythm, and S1 S2 was heard normally. GIT, abdomen was soft, liver was palpable, 2 centimeter below the right costal margin, and no abdominal distension. CNS examination, normal. Till now, we get a provisional diagnosis of acute glomerulonephritis with hypertension. Since she presented with cola-colored urine and she was having headache for past 1 week, mostly it is pointing towards some acute nephritis with hypertension, sir. Can I move on to the investigation side, sir?
Yes, please.
On investigation, on complete blood count, we got HP on the lower side and platelet thrombocytopenia. Blood urea creatinine found to be normal. Electrolytes was found to be normal. Then LFT was found to be normal. There was predominantly thrombocytopenia and mild anemia. Lipid profile was on normal range. Thyroid function test was normal. Inflammatory markers, LDH was mildly elevated. It was 431, and DCT found to be weakly positive. 24-hour urine protein was found to be in the subnephrotic range, more than normal. On urine microscopy, RBC was found to be plenty, and urine PC ratio was about 1.04. urine culture, blood culture, and throat swab culture was sent, which was found to be normal. Peripheral smear showed microcytic hypochromic anemia and mild thrombocytopenia. We sent a nasal swab, which was found to be normal for all the viruses enlisted. Then we did a complement C3, C4. C3 was initially on the normal side, sir. Then it was found to be lowering by after 3 weeks. Initially, when the child was admitted on 10th of March, complement C3 was normal. Then on 4th of April, complement was on a lower side. C3 was normal on lower side, and C4 was lower side. We did a ANA-IF, which was found to be positive 1+, showing a cytoplasmic speckled pattern. Then we did a ANA profile showing double standard DNA borderline positive. And then titer was found to be normal. Anti-double stranded DNA, ELISA found to be in the normal range, 18.3. Findings from this girl is she was having mild anemia, no leukopenia, thrombocytopenia was there. LDH was elevated. C3 was initially normal, then it went to a lower side. C4 was low. ANIF positive 1+ with cytoplasmic speckled pattern. ANA profile showed borderline double standard DNA. DCT was weakly positive. Proteinuria present, hematuria present, and urine PC ratio was high. Imaging, USG abdomen was done, which was normal study, and USG forearm was taken in view of a swelling, which was instantly found. It was suggestive of some vascular malformation in the right forearm. Renal artery Doppler was done to rule out bilateral renal artery stenosis, and it was normal. Echo done was normal. Course in the hospital. She was a 12-year-old girl child, was admitted with a history of abdominal pain, intermittent headache, and cola-colored urine, found to have a hematuria, hypertension, thrombocytosis, and obesity. A provisional diagnosis of acute glomerulonephritis was made. During hospitalization, serial monitoring demonstrated intermittent hypertension, managed with the titrated dose of oral nicardipine along with salt restriction. Renal function remained preserved throughout admission, although microscopic hematuria and mild proteinuria persisted. Blood and urine culture remained sterile. ASO titer were not significantly elevated, and mycoplasma serology was negative. A weakly positive diet Coombs test and elevated LDH suggested an associated immune-mediated hemolytic process. Extensive evaluation for secondary causes of nephritis was undertaken. Autoimmune workup demonstrated weakly positive ANA, borderline anti-double stranded DNA, low C3, and persistently low C4, raising suspicion of systemic lupus erythematosus with lupus nephritis. Multidisciplinary evaluation was done. Pediatric cardiology assessment found to be normal. Ophthalmology evaluation revealed no papilledema. Throughout the hospital stay, child remained hemodynamically stable with preserved renal function. She received supportive treatment, including salt restriction, oral nicardipine, paracetamol, Pandoc, and other topical medications were used. At discharge, working diagnosis was acute nephritis with a thrombocytopenia and transient hypertension with a suspected SLE, lupus nephritis under evaluation, referred to SAT for pediatric nephrology consultation. And on further evaluation at SAT, child showed a urine protein creatinine of 0.9. 24-hour urine protein was a little bit more raised, 519 mg per day. Prolonged PTINR APTT. So autoimmune workup was done, which revealed ANA positivity, low C3, C4 level, and anti-phospholipid antibody positivity, and positive lupus anticoagulant, and positive anticardiolipin antibody IgM. Viral markers were non-reactive. Rheumatology evaluation documented bilateral wrist and knee pain, back pain, difficulty in climbing stairs and squatting, moderate hair fall, and generalized itching, predominantly scalp, with no history of rash or photosensitivity. The overall impression was SLE with hypocomplement anemia, mild antiphospholipid antibody positivity, anemia, and thrombocytopenia without evidence of any active lupus nephritis. Child was started on hydroxychloroquine and naproxen from SAT. And recently, 1 week back, she was again admitted with complaints of worsening joint pain over the preceding 2 days and hematuria. On admission, child was found to have severe thrombocytopenia, platelets of about 10,000. And in view of active disease and with a significant hematological involvement, IV pulse dosed medial prednisolone was initiated and given for 5 consecutive days, and then tapered to oral steroid at 1 mg per kg per day. Repeat C3 and C4 levels normal, BCT negative, ASO is raised. Following improvement in the platelet count, a renal biopsy was performed for the evaluation of suspected lupus nephritis and to guide further management. Report is awaited. And we started with mycophenolate mofetil therapy at 600 mg per meter square. Coming to the ACR ULAR ACLE criteria, she got fitted into hematologic thrombocytopenia and immunological domains, anticardiolipin antibody, lupus anticoagulant positivity, and she was having low C3 and low C4, and anti-double stranded DNA antibody positive. A total of 12, which was fitting the ACR SLE criteria. And based on the SLIC criteria also, she got fitted into arthritis, renal criteria with proteinuria more than 500 mg per 20 per day, hematology criteria and immunological criteria.
Thank you, Roshni. Can you go back to the slide where you said summarize the findings? Yeah. So obviously, hematuria, color-colored urine, our first differential diagnosis is post-infective acute glomerulonephritis. There is no doubt about it. This patient has got nephritic syndrome, acute nephritic syndrome. So what was odd in rest of the investigations at that stage? Why would a patient with acute nephritic syndrome have thrombocytopenia? So that should make us, you can get anemia because of blood loss, because patient is having chronic hematuria, but it does not explain thrombocytopenia. Again, in these patients, you can get low C3, but it's unusual to get low C3 and C4. So just going back to our entrance question 25 years back, what are the causes of low C3? Lupus nephritis, post-infective acute glomerulonephritis, and membranoprophytic glomerulonephritis. But you do not consistently get low C3 and C4, and that should get better in these patients. So the persistently low C3 and C4 would make me worried. And I think this patient at that point has got, I find it slightly difficult to interpret the antibodies the way it is done here, but it looks like if you've got immunofluorescence, that is definitely suggestive of a positive ANA, which one should not expect in a patient with acute glomerulonephritis. So 9 out of 10 patients with color-colored urine or nephritic syndrome you see in your practice would be acute glomerulonephritis. But the whole idea of investigating these patients is to make sure that you do not miss that 1/10th loop patient who may be a lupus. So it is mandatory that if your sports thrombus, anything that doesn't fit in with the original picture, like thrombocytopenia and hypocomplementemia, and again, why should this patient have positive direct Coombs test? So it tells you that this patient has got thrombocytopenia and hemolytic anemia, which does not fit in with the presumed diagnosis. So those patients need to mandatorily have a screen for lupus. And I think you've done absolutely right thing. This patient has got positive ANA. Again, I couldn't quite understand the double-stranded DNA thing, but then now the important thing to remember is in the the second patient I discussed, this patient had abnormal, she had definitely evidence of acute kidney injury. Her creatinine was almost double and her GFR was half. But even she did not have a high proteinuria at the start. But after the treatment, I was just checking with my trainees the other day. When she came back, her urine protein creatinine was scored for 600. It is not unusual for us to see patients with acute kidney injury in lupus to have not massive amounts of your proteinuria, but then once we treat, that comes out. Sometimes it becomes high. So it doesn't totally surprise me that this patient's urine protein creatinine was very high. So at this stage, this would have been the perfect stage to do a kidney biopsy. Now I know we've got constraints around that because that is when this should be undertaken. Because if any patient with suspected, if the antibody profile and complements are suggestive in a patient with nephritic picture, that is an absolute predictor of what is the best way to treat this patient. So it is not just to confirm the diagnosis, but also your decision making about treatment. And you can go forward now. move the slide next to move. You can move to the next slide. Yeah. Ultrasound abdomen was normal. Yeah. Yeah. Just go back to that one, previous one. Sorry.
Suppose
Yeah, positive ANA borderline. Yeah. So at this point, this patient was started on just naproxen. Is that right, or is it the next slide?
it's the next slide.
Yeah. Okay. So this, go back to that previous slide, please. Yeah, discharge working diagnosis was no, the next one. Sorry. Yeah, the working diagnosis was acute nephritis with thrombocytopenia suspected. Yeah. So I think this patient clearly had slick criteria for diagnosis of lupus right from the start. So if we could do it all over again, I think that if the nephrologists are happy with the platelet count of 60,000, that was the best time to do the biopsy to confirm the diagnosis. Now the problem here is this patient has got a diagnosis of lupus without anything else like drugs to suggest an alternate etiology. And even if the nephritis has settled down, we should treat the lupus. That is the dictum. So this patient not only did not get lupus treatment, but got started on naproxen, which is absolutely contraindicated. In a patient with suspected lupus nephritis, naproxen should not be given. We say an absolute no-no to NSAIDs. So although the nephritis has settled down, given the background of lupus and low complements, I would have been very wary to start them on naproxen. I would probably have started them on steroids if you want to give anything for the joints. The best option would have been to give steroids because at least it is not going to do any damage. It may actually treat the nephritis as well. But I'm always wary of doing, sometimes the patient, when they come in acute kidney failure, we have to start steroids straight away and then do the biopsy. And two or 3 days of steroids is not going to massively change the biopsy. But this, so the things I would recommend is when the patient came first time and was in, say, there was a few odd things than just diagnosis of like post-infective or post-streptococcal acute glomerular nephritis, that would have been a good time to do biopsy. But even if the patient's renal parameters had settled down, but because of the antibodies and the complements, we should have started treatment at that point, and that would have prevented the second presentation of hematuria, if that makes sense. And so I think MMF is a decent medication for.
No, Kishore, can I ask you something? Like,
Yeah.
can I ask you, see, the child had nephritis. Initially, the child presented to us with nephritis, and at that time itself, thrombocytopenia was there, ANA was, that time itself, lupus was almost evident.
Yeah.
So, should we have started the child on steroids and MMF at that point of time, rather than waiting?
Yes, yeah, without a shadow of doubt. That is when
MMF also.
Yeah.
MMF also. Yeah. Okay. We could have started on HCQs, MMF, and steroids. Maybe
steroid and MMF.
Okay. At that point of time itself,
But my
then the
only
second
worry
episode
with this patient now is that the patient has got antiphospholipid antibody as well.
Okay.
Now, if the patient has got antiphospholipid antibody, we definitely need to start aspirin. So if the patient is on
low dose aspirin.
Yeah, low dose aspirin, 75 milligrams. So if the patient is already on steroid, hydroxychloroquine, and MMF, I would add on an aspirin. If the patient is not responding as well as you think the patient would respond, I think the best next option would be rituximab because this patient has got antiphospholipid antibodies. So this is the full diagnosis for this patient is, and hopefully the renal biopsy will show something, would be a lupus with secondary antiphospholipid syndrome and lupus nephritis. The other option
How much MMF, like the maximum MMF dose that could be given to this child? How much MMF can be given?
What is the weight?
What's the weight, Roshni?
850
weight of the
kg.
child?
50
1 gram
kg.
BD. 1 gram BD.
Okay. It's 600 mg per meter square per dose, right? That is the usual treatment.
Yeah.
Okay. So
So
can
I
be 1
think
gram BD.
the 600 meters usually equates to 20 milligrams per kilogram.
Okay.
So that roughly
Okay.
So we start with 10 milligrams per kilogram and then go up to 15, then go up to 20 normally. So if
Per
this
day,
patient,
per
what
dose,
she should,
per dose.
Yeah. What dose
Per
is
dose.
the patient on at the moment?
She's on 250 mg BD, അല്ലേ റോഷ്നി?
Uh,
Oh.
She's been
250 mg BD.
Oh,
എത്ര ദിവസമായി?
just started.
Oh,
Uh,
just
it-
started.
3 ദിവസം.
5 days.
എത്ര ദിവസമായി?
I think I would go up to 500 BD straight away because she is a big girl,
Okay.
50 kilograms.
Mm.
So I would give
Ah.
500 BD maybe as soon as possible. I'll change it. Wait for 2 weeks. If everything is stable, then go up to 750 BD.
Mm.
But then if she's still not responding satisfactorily, you can go up to 100.
Well, response means what are the things like you see the lupus, I mean nephritis part or
Everything.
I mean,
Lupus has everything. Yeah.
okay. Like you have to decrease the steroids. Like 2 milligram per kg you can give up to 2 weeks,
How
and
much
then you have
steroids
to.
is she on at the moment?
She's on 2 milligram, 1 mg, 1 mg per kg.
50. So she's on 50 milligrams once daily. Is it?
Yes.
Okay.
Yes, sir.
So I will wean her. I mean, I think steroid weaning is I will wean her prednisolone to 40 in 2 weeks, then 30 in 2 weeks, and 20 in 2 weeks until we get to then 10, and I'll reassess the situation. And we should go up on MMF accordingly. So once we drop down to 40, put her up to 750 BD and see what happens. And keep going. One of the indications for going to next treatment is, let's say in 3 months' time, if this patient is on 1 gram BD of MMF and maybe on 5 or 10 milligrams of prednisolone, but the patient still has very high double-stranded DNA and low complements, that is the time we need to think about something else. So the things I would look for monitoring is clinical response, proteinuria, full blood count, the platelet count and hemoglobin, urine protein creatinine ratio, complements, and double standard DNA. These are all things that we can monitor.
Like how frequently should you monitor dsDNA?
Not
How do
more
you
than
monitor
3
them?
monthly, once every 3 months, 3 to 6
3
months.
months.
There's no point in
But
checking
here
it.
the problem is, the ELISA has come as negative. I don't know whether it has been done properly or not. So how can we monitor? Still, that is the
That's
thing
tricky
here.
in this patient. I am pretty sure this patient will have a positive double-stranded DNA because that is the commonest predictor of lupus nephritis.
Yes.
The commonest association. If you've got strongly positive double, I have not seen a lupus nephritis patient without a strongly positive double-stranded DNA. And low
What test do you do there? Do you use immunofluorescence criteria lucillate thing there?
Yeah.
In UK or ELISA? Criteria lucillate. Yeah. The thing is, it's not available here. Available, it's very, very expensive. That's the thing. You cannot do criteria lucillate thing here, dsDNA here.
I
We
am
do
a big fan of
only
getting,
ELISA.
Yeah, so I'm a bit surprised that it is only 18, you said, isn't it? The result. It was normal, isn't it? dsDNA.
Yeah, it is normal, ELISA. I don't think it is correct. dsDNA, ELISA. So how can we monitor, like now itself it is normal? That is the problem here.
I think
with
we'll probably have
dsDNA.
to rely a lot on complements.
Compliments, okay. And the urine thing, alle.
Urine PCR. But
Urine
then
and
the patient is not proteinuric at the moment anyway, so that won't be much helpful.
okay. Then what are the things that you monitor when you're giving MMF? Like, sometimes it can cause thrombocytopenia, like it can cause bone marrow
Yeah, full
suppression.
blood count and liver function.
Okay. So should we, when LFT goes like 3 times or so, should we stop MMF like we do in methotrexate? And for time being and then restart, something like that?
So, well, that's
When
a
you give
problem in
MMF.
lupus because lupus itself can cause that. That is the problem. But yeah, I would say generally we say if the ALP goes to 3 figures, then we stop.
Stop for the time being and restart after doing repeating. That's what we do in methotrexate.
If the ALT is more than 100, then we stop. Your normal is 40, isn't it? That should be the normal, isn't it? 30 or 40 something. If it's more than 100,
Yeah, 30.
I would discontinue for 2 weeks and recheck.
So only those things that we have to, like bone marrow suppression and LFT. That's the thing. MMF.
I'm very rare. I can't remember MMF patient who had to stop it because of LFT issues. It's much more common.
It can sometimes cause diarrhea. Like one patient we had to stop because of diarrhea.
The side effect is abdominal pain. Yeah, sometimes they don't tolerate. GI intolerance is very common, but then I slowly go up on the dose. I don't go up quickly.
HCQ is lifelong, alle?
Yeah.
HCQ?
It's fine, very well tolerated. Usually 200 milligrams.
It is lifelong, right? HCQ, we usually give lifelong, HCQ.
Lifelong.
HCQS. Okay.
And
so
after,
we can.
We need to send them to ophthalmologists to look for any quinine amblyopia every 3 years or something. I don't know. It depends on the protocol. So they should be seen. An ophthalmologist to look for any evidence of hydroxychloroquine-induced retinopathy.
Yeah, they see properly. When we say that the child is on HCQ and we send to the ophthalmologist, they will see. That's okay. I think I don't know whether you remember last time when you came to Calicut, we showed you a child who presented like ITP, and we had started this child on MMF. Child is otherwise stable, urine everything is normal, but dsDNA was high. MMF, the child was an obese child, they were like 50 kg weight, and we were giving 1 gram BD MMF, and you said that nothing to be done, like just leave alone. അങ്ങനെയും ചെയ്യാല്ലേ dsDNA high ആണെങ്കിലും we were doing it from Ashwini, which is a fairly reliable thing.
But I think the problem with that is we can wait for some time. dsDNA may take some time, but even if it's 6 months, if it's still high, we'll have to add on something else or give rituximab.
Okay. Thankfully, that child's dsDNA came down. We are going to discuss that child with you next week.
I usually wait for some time and then wait for it to come down. But if it's not coming down by at least 6 months, then we immediately will have to step up the treatment.
Okay.
Rituximab would be the best option because it works very well.
If the child is not responding, I mean, okay.
So even this patient, if MMF has not brought about the result you want to achieve, or not letting you wean off the steroids, then I would be very wary of. I would probably err on the side of caution and start rituximab.
How much time do you take to bring it down to 5 milligram?
So I reduced 2 weeks. So for this girl, I think if she's on 50 now, in 2 weeks we can come down to 40, then 30, then 20, then 10, and once you get to 5, leave her on that for at least 3 months.
3 months. Then we usually we give it alternate day for some more time and then only think of stopping.
We don't. You can, once you get to 5, we can give alternate day, no problem. Yeah.
Okay.
Or you
then
can
continue
split the tablet 2.5 milligrams once daily. So, but then I would leave them on 5. So lupus patients, I'm happy. I usually want them to stay on steroids for about 6 months. Once they have got to 6 months on 5 milligrams, then we can make it alternate day and then stop.
Stop. If on drug remission for 6 months or so, we can stop. MMF, how long?
At least 3 years.
It's quite expensive, Kishore. Nalla velaya MMF ന്.
Celsepto. എങ്ങനെ rituximab വില എങ്ങനെയാ madam?
Rituximab ഞങ്ങൾക്ക് ഇവിടെ KMSCL കിട്ടും ഞങ്ങൾക്ക്. It's free.
I would strongly consider rituximab. Because if you give rituximab for this patient, then you are taking care of antiphospholipid antibody, thrombocytopenia, and renal disease, everything. And you can leave them on a small dose of MMF for maintenance. You don't have to
should we give rituximab now?
I mean, I think you can wait for 2 or 3 months, but I will have a very low threshold to give rituximab whenever. Especially if there are cost implications and rituximab is available.
No. We have rituximab here in the hospital. It's free. We can get it free.
I will probably give it.
Okay. We can wait for 2 to 3 months.
But if the patient is stable, there is no need to give it now. But yeah, if it's 3 months time, if it's not, things have not come down as well as you want it to come down, then rituximab would be the next option. Especially because she has got thrombocytopenia and has got antiphospholipid antibodies.
Should we check the antiphospholipid antibody again, like maybe after a month? Something like that should we do?
I would wait for all the antibodies to check. I'll wait for at least 3 months.
3 months. Okay.
So when you check double stranded DNA in 3 months, we can check antiphospholipid antibodies as well.
Apply korreyo? dsDNA korreyo? Ano? Apply korreyum? Oh. അപ്പൊ അതൊരു ഡിസീസ് ആക്ടിവിറ്റി ഇൻഡെക്സ് ആയിട്ട് നമ്മൾ സാധാരണ പറയാ C3, C4 and dsDNA അല്ലേ, like to be taken as disease activity.
It's not included as a disease activity index because it's only applicable to people who have it.
Okay. fine.
So 80% of our patients are APLS positive, negative. So it doesn't apply
Is
to
it
them.
negative? നമുക്കും കിട്ടാറില്ല. ഞങ്ങളുടെ കോഹോർട്ടിലും വളരെ കുറച്ച് പേരെ
In fact, we
ഞങ്ങൾ
have got
കണ്ടിട്ടുള്ളൂ.
One twin brother has got primary antiphospholipid antibody syndrome, and the other twin brother has got lupus with secondary antiphospholipid antibody syndrome.
Oh,
that's very rare.
ഈ കുട്ടിക്ക് ജീനോം ആവശ്യമില്ലല്ലോ. മോണോജനിക് ലൂപ്പസ് വി ആർ നോട്ട് സസ്പെക്ടിങ് അല്ലേ, ബിക്കോസ് ഇറ്റ്സ് എ ഗേൾ, കോമൺ, പക്ഷെ ഫാമിലി ഹിസ്റ്ററി ഇല്ല അല്ലേ?
Very typical for a standard lupus.
Okay, fine.
So I won't check our whole genome unless they are less than 5 years or something.
Yeah. Or there is a family history.
Or if there are very classical clinical features of lupus without ANA. That's another group where we can suspect this.
നിങ്ങൾ അവിടെ ANA HEP2 തന്നെയാണോ ഇപ്പോഴും ചെയ്യുന്നത് UK-ല്? or has it changed? HEP2 സെൽസ് മാറിയോ? ഇല്ല, അതന്നെയല്ലേ?
അതാണ് അമേരിക്കൻ കോളേജ് ഓഫ് പെത്തോളജിയുടെ ഗോൾഡ് സ്റ്റാൻഡേർഡ് ഇതാണ്.
HEP2 തന്നെയാ. ഇന്നലത്തെ മറ്റേ ഇതിലും അതന്നെ പറഞ്ഞത്. അമിത മാഡം വാസ് ഡിസ്കസിങ് അബൌട്ട് ലൂപ്പസ്. ഷീ സെയിങ് ഇപ്പോഴും HEP2 തന്നെയാണ് ഗോൾഡ് സ്റ്റാൻഡേർഡ്. ഷീ വാസ് സെയിങ് in the national conference. അങ്ങനെ. Anyway, shall we wind up, or there is one more case? Shall we discuss that?
I don't know.
Kishore, are you feeling hungry? Kishore വിശക്കുണ്ടോ? One more case, like, അതൊരു ചെറിയ കേസാണ്. PSRA ആണോ റുമാറ്റിക് ഫീവർ ആണോ എന്നൊരു കൺഫ്യൂഷൻ. 10 minutes ഡിസ്കഷൻ തീർക്കാം. Is it okay for you? Hello?
Okay, madam. Okay, madam.
Okay ആണോ? Karthika, are you there? Can you present? Karthika? Roshni, can you ask Karthika to present that? Karthika ഇല്ലേ?
Yes, ma'am. I am here. I will present the case.
Karthika, അതൊന്ന് ഷോർട്ട് ആയിട്ട് പറഞ്ഞു, വളരെ ഷോർട്ട് ആയിട്ട്. Just 10 minutes കൊണ്ട് തീർക്കാം. You can share the same laptop, you can use റോഷ്നിയുടെ തന്നെ അല്ലേ?
ഒരു മിനിറ്റ് മാഡം, ഞാൻ ഷെയർ ചെയ്തോണ്ടിരിക്കുകയാണ്.
അത് SLE അല്ല കേട്ടോ കിഷോർ, അത് മറ്റേ ഒരു ആർത്രൈറ്റിസ് ആണ്. നമുക്ക് കിഷോർ, ക്യാൻ യു ഹിയർ മീ? ഓക്കെ. PSRA ആണോ അങ്ങനെ ഒരു ഡൗട്ട്, അത്രേ ഉള്ളൂ. റുമാറ്റിക് ഫീവർ അല്ല തോന്നുന്നു, അങ്ങനെ ജസ്റ്റ് നമുക്കിപ്പോ വി ഹാവ് നോട്ട് മച്ച് ഓഫ് റുമാറ്റിക് ഫീവർ കേസസ്, വളരെ കുറവാണ്. അവിടെ പിന്നെ ഉണ്ടാവില്ലല്ലോ അല്ലേ? ലൈക്ക് വി യൂസ് ടു ഹാവ് when you were PGs ഒക്കെ, അത്രയും റുമാറ്റിക് ഫീവർ നമ്മളിപ്പോ കാണുന്നില്ല ഇവിടെ. അതെ, അന്നൊക്കെ അങ്ങനെയായിരുന്നല്ലോ. അവിടെ നിന്നോ? അവിടെ ഉണ്ടായിട്ടുണ്ടോ?
ആന്റിബയോട്ടിക് പോളിസി ആണ്. ബ്ലാങ്കറ്റ് ആയിട്ട് പെൻസിലിൻ കൊടുക്കാനൊന്നും പറ്റില്ല എന്ന് പറഞ്ഞാൽ സ്ട്രെപ്റ്റോകോക്കസ് ത്രോട്ട് സ്വാബ് കൺഫേംഡ് ഇതിനെ ആന്റിബയോട്ടിക് കൊടുക്കുള്ളൂ.
സ്ട്രെപ്റ്റോകോക്കസ് ത്രോട്ടിൽ കിട്ടില്ലല്ലോ, അങ്ങനെ കിട്ടുമോ റുമാറ്റിക് ഫീവറിൽ? അത് പോസ്റ്റ് അല്ലേ?
റുമാറ്റിക് ഫീവറിലല്ല ഞാൻ പറഞ്ഞ, സാധാരണ സോർ ത്രോട്ട് വരുമ്പോൾ അതുകൊണ്ടാണ് അവിടെ വരുന്നത്. അവര് ത്രോട്ട് സ്വാബ് ചെയ്തിട്ട് ഇതുണ്ടെങ്കിലേ ആന്റിബയോട്ടിക് കൊടുക്കുള്ളൂ. അല്ലെങ്കിൽ സൈനോ, ഒന്നെങ്കിൽ ഫോളിക്കിൾസോ അല്ലെങ്കിൽ എക്സുഡേറ്റോ എന്തെങ്കിലും ഉണ്ടാവണം, അല്ലെങ്കിൽ ത്രോട്ട് സ്വാബിൽ ഉണ്ടെങ്കിൽ ആന്റിബയോട്ടിക് കൊടുക്കും. അപ്പൊ ചില സ്റ്റെപ്പ് മിസ് ചെയ്താൽ ഉണ്ടാവും.
കാർത്തിക റെഡി?
ഹലോ മാം,
വേഗം പറഞ്ഞോ.
സ്ക്രീൻ കാണാമോ?
കാണാം. പറഞ്ഞു.
Good afternoon, everyone. So my case is about post.
This is Dr. Karthika Kishore. She is our JR2, junior resident 2, second year. She had her duty yesterday. ഞാൻ നിർബന്ധിച്ച് ചെയ്യിപ്പിച്ചതാ പാവം. I think she is tired. Still she has agreed to do. പറഞ്ഞു.
Okay, the child presented with complaints of abdominal pain for 1 week, which was diffuse, intermittent, non-radiating, and loose stools for 1 week, watery multiple episodes per day, with no blood or mucus in the stool. 4 days later, the child developed migratory kind of joint pain and swelling. The swelling first developed on right wrist, followed by left ankle, left hip, then left knee. The left hip and left knee joint involvement were together. Then the child had difficulty in walking, restricted mobility due to severe left hip and left knee pain for the past 2 days. The child was apparently well until 1 week prior to admission. Then he developed abdominal pain. The pain was diffuse, intermittent, non-radiating, and was not associated to any food intake. It was associated with loose stool, which began on the same day. Stools were watery in consistency, passed multiple times a day, with no history of blood or mucus in the stool. There was no history of vomiting, abdominal distension, or constipation. No history of food intake from outside. On the third day of hospitalization, the child developed pain and swelling on the right wrist. The pain was acute in onset, severe enough to restrict movements of the wrist, and was aggravated by movement. The swelling was diffuse and associated with tenderness, with no local warmth, redness, history of trauma, insect bite, or discharge. The symptoms over the right wrist subsided completely over the next 2 days, following which the child developed pain and swelling over the left ankle. Subsequently, he developed severe pain involving the left hip and left knee simultaneously. The pain was severe enough to markedly restrict mobility, making standing, walking, and weight bearing difficult. The joint involvement was migratory in nature, with symptoms resolving in one joint before the appearance of symptoms in another, except for the left hip and left knee, which remain involved concurrently. There was no history of fever during the present illness, no history of chest pain, palpitation, breathlessness, syncope, involuntary movement, no history of skin rash or subcutaneous nodule, no history of oral ulcer, no history of weight loss, loss of appetite, easy bruising or bleeding, or similar episodes in the past. There was no history of contact with tuberculosis. So the child developed abdominal pain. Loose stools also began on the same day. On day 3, the child had right wrist pain and swelling. On day 5, the symptoms resolved. Left ankle was involved. On day 6, there was left hip plus left knee pain, which was concurrent, which was severe. On day 7 to 8, the child was unable to bear pain and was admitted. So the child had a history of pyoderma 1 month before onset of this illness. Sore throat 2 weeks before onset, lasted for 4 days. The child was febrile during that period. No antibiotics were given. The child was managed symptomatically. There is no history of trauma, insect bite, or similar past episodes. Background and development. The child is a second child of non-consanguineous marriage, maternal age 30, spontaneous conception. Antenatal and postnatal period were uneventful. The child is fully immunized. No significant family history present. On general examination, the child was alert and oriented. Anthropometry, weight, height, and BMI were appropriate for age. Vitals were stable. The child was maintaining the left hip and left knee in a position of comfort. The child was unable to bear weight on the left lower limb because of pain. Oral cavity, there was no pharyngeal congestion. There was no rash, no erythema marginatum present. Scars of pyoderma, the lesion which was there 1 month back was present. No active skin lesions were present. On examination, there was no swelling over right wrist, no local warmth or erythema. Over lower limb, there was swelling and tenderness over the left knee with painful restriction of movement. Left hip movement were also painful and restricted. Left ankle and both wrist appears normal. There was no muscle wasting or limb length discrepancy. On PGL's examination, the child was unable to walk due to severe pain in the left hip and left knee. On inspection of arms, there was no deformity or muscle wasting. The previous swelling was resolved. All other small joints, shoulder, elbow, wrist, full range of motion. Grip strength was appropriate for each. Legs, there was swelling with tenderness and painful restriction of flexion and extension. No erythema or local warmth over left knee. Left hip also, there was painful restriction of flexion, extension, abduction, adduction, and internal rotation. Left ankle, there was no active swelling. Right lower limb were normal. There was no fixed deformities. Spine examination and systemic examination were within normal limit. On investigation, the CBC showed leukocytosis with neutrophilic predominance. ESR and CRP were elevated. ASO titer was significantly elevated. ECG showed normal PR interval. Throat, stool, blood, and urine culture was sterile. We have done an ultrasonography of left hip, which showed left hip joint infusion. On echocardiography, there was no evidence of carditis or valvular involvement. So in this case, latent period was after sore throat was short, which favors PSRA. Arthritis pattern was migratory, but there was addictive involvement of hip and knee. The response to NSAID was dramatic. We have started the child on naproxen, and the child improved rapidly within 2 days. There was no history of carditis. The ECG showed normal PR interval. ASO titer was significantly elevated. The child was admitted with complaints of migratory polyarthritis following a recent sore throat. At admission, he was hemodynamically stable and was initially managed symptomatically with analgesics and supportive care. Blood investigation revealed leukocytosis with neutrophilic predominance and elevated inflammatory marker, including ASR and CRP. ASO titer was significantly elevated. ECG showed a normal PR interval. Throat swab culture, stool culture, blood culture, and urine culture was sterile. USG of the left hip demonstrated left hip joint effusion. Echocardiography was performed and showed no evidence of carditis or valvular involvement. In view of the history of preceding streptococcal pharyngitis, elevated ASO titer, migratory kind of arthritis, absence of carditis, and normal PR interval, a diagnosis of post-streptococcal reactive arthritis was considered. The child was started on naproxen, following which there was rapid symptomatic relief with significant reduction in joint pain and improvement in mobility. The child remained afebrile and hemodynamically stable throughout the hospital stay. He was discharged in a stable condition on secondary penicillin prophylaxis with advice for regular follow-up. In view of the risk of delayed cardiac involvement, periodic cardiology review with repeated clinical evaluation, echocardiography was advised. That's all.
Kishore, the thing is, every migratory in the the child was put on ibuprofen from the local hospital. So the child was given ibuprofen when the child had arthritis. They were saying migratory, that time. But when the child came, only the hip and the knee seemed to be severe pain. We thought initially it is cellulitis because there was a swelling also on the hip, on the thigh. But USG revealed only hip joint effusion, which was persisting, and we had given IV antibiotics thinking maybe it's a septic arthritis or something like that. But child did not have fever. That was the thing. So things were not fitting in. It was not fitting in with Jones criteria because PR interval normal, carditis illa, arthritis and odd arthritis, hip persistent.
Fever
ഇല്ല ഫീവർ കാര്യമായിട്ടില്ല. ഞങ്ങൾ IBD ആലോചിച്ചു, പക്ഷെ പാസ്റ്റ് ഹിസ്റ്ററി ഓഫ് IBD റിയാക്റ്റീവ് ആർത്രൈറ്റിസ് ഇങ്ങനെ ഹിപ്പ് അതായിരുന്നു. പിന്നെ that was another thing we were thinking, reactive arthritis, but we didn't give aspirin because not sure about the diagnosis of rheumatic fever. We gave naproxen. Atra dramatic response Karthika parana pole 3-4 days ഉണ്ട് വേദന മാറി. We gave a penicillin prophylaxis 7 days. We gave IV antibiotics and we switched over to penicillin prophylaxis. അങ്ങനെയാണല്ലോ PSRA പറയുന്നത് 1 year we have to give, no? So now the child is discharged on naproxen and we don't know whether we are correct, and penicillin prophylaxis.
I agree, it's tricky, this one. I personally feel this is more PSRA because one, there is no fever. Secondly, the response to NSAID was less dramatic. Aspirin, one thing we find in rheumatic fever is the pain is excruciating. It is disproportionate to what you can find on examination.
അത് ഈ കുട്ടിക്ക് അങ്ങനെയായിരുന്നു. It was disproportionate കുറച്ച്.
But then it responds dramatically. നമ്മൾ പണ്ട് പറഞ്ഞ aspirin melts the arthritis. It disappears within 72 hours of giving aspirin or NSAID for that matter. So whereas in PSRA, it doesn't have to be migratory, it can be additive, and the response is less dramatic than in rheumatic fever. So if you don't have anything else to substantiate rheumatic fever, and even with PSRA, you would give penicillin for 1 year, do an echo if it's normal, and then stop.
Yes. After a year, we can do.
That is reasonable. Yeah, I don't think this patient needs steroids in any shape or form. But with regards to IBD, the red flags would be: is the albumin low or normal?
It was normal. LFT was normal.
But then obviously the arthritis in IBD will not go away until you treat the IBD.
Until you treat
the IBD.
Yeah, we have not done.
They refer patient about IBD arthritis. I tell the gastroenterologist, you treat the IBD, the arthritis will go away. So I don't think, because the gastric symptoms GI symptoms were very brief, although it's a very good differential to have, I think because the arthritis has settled down, I don't think it's IBD. If it's IBD, the inflammatory markers will persistently remain high, and the albumin will start dropping.
Okay, I think albumin was normal. I had seen to that. ഈ rheumatic fever ആണോ PSRA ആണോ എന്നുള്ള aspirin I'm slightly hesitant to give because we have had bad experiences Ray's syndrome giving aspirin to non-rheumatic fever patients. ഒന്ന് രണ്ടെണ്ണം. Priya sir
Still
never
use
allows
aspirin
us
for
to give.
rheumatic fever?
Yeah, here we use aspirin for rheumatic fever.
Okay, same dose, high dose.
Same high dose. That's what the textbook says. 60 to 70, 80 mg, 80.
I think this patient has got more features to suggest PSRA than rheumatic fever. So I think it's a reasonable take, especially without any carditis. I think it's reasonable to continue naproxen for how much ever is indicated.
Yeah, maybe now they are decreased the time 6 to 8 weeks മതി എന്നാണ്. പണ്ടത്തെ മാതിരി 3 months തന്നെ പറയുന്നില്ല.
6 to 8 weeks of NSAID, penicillin prophylaxis, follow up for 1 year. If at 1 year everything is fine, and do an echo. If the echo is normal, just discharge. Stop the penicillin.
Yeah, that will be okay for this child because I didn't want to brand this child as acute rheumatic fever. പിന്നെ അതൊരു brand ആവും. Then you have to continue.
Lifelong, you are condemning patient to lifelong penicillin prophylaxis. So, or at least 5 years. So I don't think.
Yes. That's what. And hip involvement per se, itra kalam nikkunna very unlikely alle rheumatic fever la. Alle axial involvement is not very likely. Alle the persistent item.
Hip involvement is very rare in rheumatic, but usually knees and ankles, and sometimes elbows and wrists. You don't get anything. Usually lower limb joints.
Yes. ഇത് അങ്ങനെയല്ലല്ലോ.
Hip ഉള്ളോണ്ട് IBD suspect ചെയ്യണം നല്ലതാണ്. പക്ഷേ ഈ പറഞ്ഞ മാതിരി ആൾക്ക് inflammatory markers normalize ചെയ്തില്ല എന്നുണ്ടെങ്കിൽ it's worth considering IBD. But otherwise, yeah, I think your plan is perfect. I would agree.
Okay, fine. Okay, fine. Thank you. So we'll just monitor the investigation and the child, and just keep the child under close follow-up for a year. They have already advised echo, repeat echo after 2 months or 1 month or something like that. We will do. That's okay. And the thing is, in rheumatic fever, even if you give naproxen, whatever, aspirin, it doesn't prevent the RHD, no? It just prevents the acute complications of rheumatic fever. It doesn't prevent the future development of RHD. That was what I was thinking when I started on naproxen. Anganelle parayunne. So, anyway, JP sir, Dr. Jayaprakash, he's our superintendent, Dr. Kishore. Are you there? Dr. Jayaprakash, I think he's gone for a meeting.
Yeah, meeting.
And Thomas, can you say the vote of thanks to Kishore then? Dr. Thomas is our intensivist, Kishore here. He's doing a great job in our ICU. Thomas?
Okay. Sir, actually it was an excellent session on various rheumatological conditions, SLE, PSRA, etc. Thank you, Kishore Chandran sir. Actually, your clear explanations and practical insights were really informative. Thanks, sir, for sparing your valuable time with us.
Always a pleasure.
Also, thanks. Okay. Thanks to Dr. Roshni, Dr. Karthia for your nice presentations. And also to Geeta madam for organizing the session. And to our HOD madam, Srilada madam, and all the faculty and residents for your kind participation.
And also our IAP president, Dr. Jayaprakash, who has, and our superintendent. Okay. Yes. Anyway, and it's always easy to organize things with Kishore because he doesn't produce complications at all, you know. So he's coming
because of technical issues.
That's okay. He's coming on the 8th to Calicut. So again, we'll be meeting there. We have about 8-10 case അവിടെ ആക്കി വെച്ചിട്ടുണ്ട് അവിടെ. Let us see. Okay. You know, you remember the child you presented online? ആ കുട്ടീനെ ഒന്നും കൂടെ, the child has a relapse now. Remember that child, CRMO bar ERA, ഓർമ്മയുണ്ടോ കിഷോർ? That child has adalimumab kuti, but child has had a relapse, I think. I don't know what actually happened. That child, I think they are going to present. പറയുന്നുണ്ട് ആ കുട്ടീനെ. The child is on adalimumab. അതുണ്ട്.
ആദ്യം CRM ആയിട്ട് തുടങ്ങി പിന്നെ കുറച്ചൊരു ആക്സിയൽ ഡിസീസ് വന്ന കുട്ടിയല്ലേ?
അതന്നെ. You present in the IAP platform. You remember, boy, 8-year-old. Yeah, that child. മേൽപ്പുറത്തുള്ള കുട്ടി അതന്നെ അതന്നെ പാമിഡ്രോണേറ്റ് നമ്മൾ കൊടുത്തിട്ടുണ്ടായിരുന്നില്ല. വി വർ ഗിവിംഗ് അഡലിമുമാബ് ആക്ച്വലി. ബട്ട് നൗ ഐ തിങ്ക് റീസെന്റ് ട്രിനെറ്റ് വാസ് സെയിങ് ദ ചൈൽഡ് ഹാസ് റിലാപ്സ്. എനിക്ക് ഡീറ്റെയിൽസ് അറിയില്ല. എനിവേ ദേ ആർ ഗോയിങ് ടു പ്രസന്റ് ഇറ്റ് നെക്സ്റ്റ് വീക്ക്. പിന്നെ ഓക്കെ. സോ താങ്ക് യു കിഷോർ. വിശക്കുണ്ടോ? ഊണ് കഴിച്ചിട്ട് വടക്കാഞ്ചേരിക്ക് പോവാ. സോ കാലിക്കറ്റിലേക്ക് കമ്മിങ് ഫ്രം വടക്കാഞ്ചേരി അല്ലേ? ഓക്കെ. വന്ദേ ഭാരത്. എനിക്കൊന്ന് ടൈമിംഗ് ഒന്ന് അയച്ചു തരണേ ട്രെയിനിന്റെ കറക്റ്റ് ടൈം. ഓക്കെ ഓക്കെ. താങ്ക് യു വെരി വെരി നൈസ്, വെരി ഇൻഫോർമേറ്റീവ് സെഷൻ. താങ്ക് യു.